Today we're diving into a critical topic in liver health, hepatitis and cirrhosis. We'll be drawing from Chapter 56 of Liver Disorders, a comprehensive source that details these conditions, their causes, and management. Rachel, let's start with the basics. What exactly is hepatitis, and how does it differ fundamentally from cirrhosis?
Hepatitis, at its core, is an inflammation of the liver cells. It can stem from various sources, most commonly viral infections, but also from toxic agents like alcohol or certain medications. It can also appear as a secondary infection alongside another virus. Cirrhosis, on the other hand, represents the permanent scarring of the liver. This scarring is typically a result of chronic, prolonged inflammation, which means hepatitis, if left unchecked, can actually lead to cirrhosis.
So one can lead to the other. You mentioned viral hepatitis being the most common. Could you elaborate on the types and how these different forms are acquired?
Certainly. Viral hepatitis comes in several major categories: hepatitis A, B, C, D, and E. Each has distinct transmission routes. Hepatitis A and E are primarily transmitted via the fecal-oral route, often through ingesting contaminated food or water, especially shellfish for Hep A, or fecal waste for Hep E. The source material notes that Hep E is more common in less developed parts of the world.
The fecal-oral route makes sense for food and water contamination. What about hepatitis B, C, and D? These seem to have a different set of risks.
They do. Hepatitis B, C, and D are predominantly blood-borne. Hepatitis B is often transmitted through unprotected sex with an infected individual, from infected mothers to their infants, or contact with infected blood, including through injectable substance use. Hepatitis C also spreads through injectable substance use, contaminated blood products, or organ transplants, particularly before 1992 when screening was less rigorous, and through contaminated needle sticks or unsanitary tattoo equipment. Sexual contact is also a route.
And hepatitis D then, does it exist independently or is it linked to the others?
Hepatitis D is unique because it requires co-infection with hepatitis B. You can't have Hep D without Hep B. Its risk factors mirror some of Hep B's: injectable substance use and unprotected sex.
It's quite striking how some individuals can carry these viruses without even knowing. The source mentions they might be free of manifestations, yet still contagious. That creates a significant public health challenge, doesn't it?
It absolutely does. That's why health promotion and disease prevention are so vital. Following CDC vaccination recommendations is key, particularly for hepatitis A and B, for which vaccines are available. Rigorous infection control practices are also crucial, especially safe injection practices. That means aseptic technique for parenteral medications, using sterile, single-use needles and syringes, and opting for single-dose vials whenever possible.
So beyond medical settings, what can individuals do in their daily lives to prevent transmission?
Proper hand hygiene is paramount before preparing food, after using the toilet, or changing diapers. If traveling to underdeveloped countries, drinking purified water and avoiding sharing eating utensils and bed linens are critical steps. Other risk factors include unscreened blood transfusions prior to 1992, hemodialysis, and percutaneous exposure through dirty needles, body piercing, tattooing, or sharing personal hygiene tools like razors.
Once infected, what are the typical signs and symptoms someone might experience or a clinician would look for?
Initially, individuals might report a history of exposure to infected blood, stool, or body fluids. They often present with influenza-like symptoms: fatigue, decreased appetite with nausea, abdominal pain, and joint pain. On physical assessment, fever, vomiting, dark-colored urine, clay-colored stool, and jaundice, which is yellowing of the skin or eyes, are common indicators.
And how do doctors confirm a diagnosis and differentiate between the types of hepatitis?
Laboratory tests are essential. They check liver enzymes like ALT and AST, which are usually elevated, and alkaline phosphatase and total bilirubin levels. The key to differentiating viral types lies in specific antibody and antigen tests. For example, anti-HAV antibodies indicate hepatitis A. For hepatitis B, the presence of hepatitis B surface antigen, or HBsAg, shows the individual is infectious, though a vaccinated person can also show a positive HBsAg, indicating immunity. Hepatitis C is detected by anti-HCV antibodies or RNA PCR tests. Hepatitis D is identified by intrahepatic delta antigen or anti-HDV antibodies, and Hep E by anti-HEV antibodies.
Beyond blood tests, what about more invasive diagnostic tools?
A liver biopsy is considered the most definitive diagnostic approach. It helps identify the intensity of the infection and the degree of liver damage. It's a procedure where a sample of liver tissue is collected. Before the biopsy, clients typically fast from midnight and might receive sedative medications. During the procedure, the client is positioned supine and they're instructed to exhale and hold their breath while the needle is inserted. Afterward, the client needs to lie on their right side for several hours to compress the liver capsule and reduce bleeding risk. Monitoring for abdominal pain, bleeding from the puncture site, and even signs of pneumothorax due to accidental lung puncture are crucial.
That sounds like a serious procedure with significant post-care. What does the nursing care entail at once a diagnosis of hepatitis is made, and what are the treatment options?
Most clients with hepatitis are cared for at home unless they're acutely ill. Nursing care focuses on promoting hepatic rest and tissue regeneration. This means administering only necessary medications, avoiding alcohol, and limiting physical activity. A high carbohydrate, high calorie, moderate fat, and moderate protein diet is encouraged after nausea subsides, along with small, frequent meals. Education on preventing disease transmission, like avoiding sexual intercourse until antibody testing is negative, and practicing proper hand hygiene is also vital.
And the medications?
For hepatitis A, immunization is recommended for post-exposure protection and immunoglobulin for certain high-risk groups. Acute hepatitis B and E usually involve supportive care with no specific medications. Chronic hepatitis B, however, can be managed with antivirals like tenofovir or lamivudine. For hepatitis C, combination therapy with pegin interferon alpha 2A and ribavirin is a preferred treatment.
What happens if hepatitis isn't effectively managed or progresses? What are the long-term complications?
Untreated or chronic hepatitis, particularly B, C, or D, can lead to several severe complications. Chronic inflammation increases the risk for liver cancer. Fulminant hepatitis is an extremely severe and often fatal form where clients rapidly develop liver failure. And, as we mentioned, the most common long-term consequence of chronic inflammation is cirrhosis, which is permanent scarring that replaces normal liver tissue with non-functioning fibrotic tissue. This leads to impaired blood flow and bile handling, often resulting in jaundice. Liver failure and hepatic encephalopathy are further stages where toxic substances build up, affecting brain function, leading to changes in neurologic status.
So cirrhosis then is a major endpoint for many chronic liver issues. What are its specific risk factors beyond chronic hepatitis?
Absolutely. While chronic viral hepatitis is a major cause, alcohol use disorder is another significant risk factor, leading to what's known as Lion's cirrhosis. Autoimmune hepatitis, fatty liver disease, certain medications, toxins, and even chronic biliary obstruction can cause cirrhosis. There's also cardiac cirrhosis, resulting from severe right heart failure due to lack of blood flow.
What symptoms would distinguish cirrhosis from earlier stages of liver inflammation?
In cirrhosis, patients often experience persistent fatigue, weight loss, abdominal pain, and distension. Pruritus, or severe itching, is common. More concerning are confusion or difficulty thinking, personality changes, and altered sleep patterns, which are signs of waste product buildup in the brain. Physical findings can include gastroesophageal bleeding from enlarged esophageal varices, splenomegaly, ascites, which is fluid buildup in the abdomen, jaundice, petechiae, spider angiomas, and dependent peripheral edema. Advanced signs include asterixis, or a coarse hand-flapping tremor, and fador hepaticus, a fruity or musty breath odor.
Those sound like very advanced and distressing symptoms. How do lab tests reflect the severity of cirrhosis?
In early stages, liver enzymes like ALT and AST might be elevated, but as the liver fails, they can return to normal because the cells are no longer capable of an inflammatory response. ALP increases due to biliary obstruction. Bilirubin levels are consistently elevated because the liver can't excrete it. Critically, blood protein and albumin levels decrease due to impaired hepatic synthesis. Hematological tests show decreased RBCs, hemoglobin, hematocrit, and platelet count. PT-INR is prolonged, indicating clotting issues, and ammonia levels rise significantly as the liver can no longer convert ammonia to urea for excretion. Creatinine can also increase, signaling kidney dysfunction.
The liver biopsy you mentioned earlier, is it performed differently for cirrhosis patients given the increased risks?
Yes, for cirrhosis, liver biopsies are still the most definitive way to assess progression and extent. However, due to the increased risk of hemorrhage in these patients, a radiologist might perform the biopsy through the jugular vein, threading it to the hepatic vein. This approach, guided by fluoroscopy, minimizes bleeding complications. Patients with cirrhosis also face specific nursing care challenges due to their various symptoms.
What does that specialized care involve?
It's comprehensive. Monitoring respiratory status is vital because ascites can compromise breathing. Skin integrity is a major concern due to pruritus and pressure injury risk. Fluid balance is closely managed with strict INOs, daily weights, and abdominal girth measurements for ascites, often involving fluid and sodium restrictions. Neurologic status is constantly assessed for signs of hepatic encephalopathy, often managed with medications like lactulose to excrete ammonia. Nutritional support is key, typically a high carbohydrate, high protein, moderate fat, and low sodium diet with vitamin supplements.
You mentioned lactulose for encephalopathy. What other medications or procedures are common for cirrhosis?
Diuretics are used for fluid retention. Beta blockers can prevent bleeding from varices. Aside from lactulose, non-absorbable antibiotics can also help manage ammonia levels. It's important to note that medication metabolism is impaired, so general medications, especially opioids and sedatives, are administered sparingly. Therapeutic procedures include paracentesis to relieve ascites, endoscopic variceal ligation or sclerotherapy to manage esophageal varices, and transjugular intrahepatic portosystemic shunt or TIPS for persistent ascites or hemorrhage. In severe cases, a liver transplant might be the only option.
A liver transplant is a major intervention. What are the key considerations there?
Transplants can use portions of healthy livers from deceased or living donors, and the transplanted portion regenerates. Patients must meet strict criteria. Those with severe cardiac or respiratory disease, metastatic cancer, or active alcohol/substance use disorder are generally not candidates. Post-transplant care is intensive, involving close monitoring for acute graft rejection, infection, clotting problems, and hepatic complications. Immunosuppressants are critical to prevent rejection.
Given the complexity of both hepatitis and cirrhosis, what's the most crucial advice for patients and their families?
The absolute most crucial advice is to abstain from alcohol. This prevents further scarring, allows tissue healing, and reduces the risk of complications. Consulting a provider before taking any over-the-counter medications or herbal supplements is also vital, as many are metabolized by the liver. Adhering to specific diet guidelines, whether low sodium for fluid retention or low protein if encephalopathy is present, is non-negotiable. And for those who undergo transplantation, understanding the importance of immunosuppressants and reporting any signs of rejection immediately is life-saving.
This has been a really comprehensive look at liver disorders, from the initial inflammation of hepatitis to the severe scarring of cirrhosis and its many complications. It underscores the importance of preventative measures and careful management.
Indeed, early diagnosis and diligent care can make a profound difference in outcomes, preventing the progression to end-stage liver disease and its life-threatening consequences.
For anyone who found this discussion insightful, consider sharing it with someone who might benefit from understanding more about liver health.